All right, so get ready, because today we're taking a deep dive into a real medical mystery.
Yeah, a real head-scratcher.
We're going behind the scenes at Grand Rounds, where a senior resident is presenting a complex neuro case
Oh, wow.
to their attending consultant.
Oh,
They'll be right there with them as they try to figure out what's going on.
I like it.
And trust me, this one throws some serious curveballs.
I bet.
What's so fascinating about this case is that the patient initially seems to have one thing.
Okay.
But as we get more information, the picture changes completely.
Interesting.
It's a fantastic example of clinical reasoning.
Definitely.
And it shows how important it is to take a thorough history, to think critically, and to be ready to change your mind when new evidence comes up.
You got it.
It really shows the challenges we face in neurology, especially with immunocompromised patients.
Absolutely. Cases like this really make you think.
So let's meet our patient.
Okay.
She's a 52-year-old woman with a history of a kidney transplant.
Already adds another layer of complexity, right?
Right. Which already makes things more complicated. She comes into the ER with a bunch of neurological symptoms.
Like what?
Tingling and numbness in her arms, trouble swallowing, slurred speech, left-sided visual field problems, and just feeling really tired.
Oh, wow.
They did a CT scan in the ER, and it was negative.
Oh.
So initially, they thought it might be a stroke or some other kind of vascular event.
Yeah, that makes sense. It sounds like a stroke at first.
But things weren't so clear-cut, were they?
What happened?
Well, they sent her home.
Oh, no.
But her symptoms didn't go away.
Oh.
And actually, they got worse over the next few weeks.
So she ended up back in the hospital.
Exactly.
Yeah.
This time at a bigger hospital with more specialized care.
Got it.
That's where our senior resident takes over.
Okay.
Now, remember, this patient is immunosuppressed.
Right, because of the transplant?
Because of her transplant, which complicates things even more.
Definitely.
But the senior resident takes all of this into account and comes up with three main possibilities for what could be going on.
What were they?
First, PML.
Progressive multifocal leukoencephalopathy.
That's the one.
Yeah.
A brain infection that's more common in people with weakened immune systems.
Right.
Second, cyclosporine toxicity.
Because of her transplant meds.
Exactly. And third, a general CNS infection.
Okay, so something other than the JC virus that causes PML.
You got it. It's really important to consider her being immunosuppressed right from the start.
I agree. It really broadens the list of possible diagnoses.
And the senior resident doesn't just stop at these possibilities. They come up with a plan to investigate further.
I like it. What did they suggest?
First, an MRI of the brain with contrast.
Classic move for neurological symptoms.
Right. Then a lumbar puncture to analyze her cerebrospinal fluid.
That can tell us a lot about what's going on in the central nervous system.
Exactly. It can help us rule out or confirm several things, especially infections.
Makes sense.
And since she's on cyclosporine, they wanted to check her levels again.
To see if she was having any problems with the drug.
Exactly. They wanted both trough and peak measurements.
Thorough.
Finally, they recommended an EEG to rule out seizures.
Sounds like a comprehensive approach so far.
But I bet our attending consultant had a few more ideas up their sleeve.
Oh, I'm sure they did. What did they suggest?
Well, first, they really stressed how important it was to get specific MRI sequences.
To look for something in particular.
Yeah. They wanted to be able to tell the difference between PML and PRS.
PRS, posterior reversible encephalopathy syndrome.
That's the one, which can happen with cyclosporine toxicity.
Ah, I see.
They recommended adding certain sequences
Okay.
that would show the lesions better and help distinguish between these two conditions.
Makes sense. Choosing the right MRI sequences can be crucial.
It's like choosing the right tool for the job.
Exactly. You want to make sure you're getting the information you need.
And because our patient had a history of TB peritonitis,
Oh, wow.
they also wanted to expand the CSF testing.
To look for something specific.
Yeah, to include fungal and mycobacterial cultures.
Given her weakened immune system, that's a smart move.
They weren't taking any chances. And to think even more broadly,
Okay.
they also wanted to do a CNS angiogram to rule out vasculitis.
Vasculitis. Interesting. That's not always the first thing that comes to mind.
But it can definitely mimic other neurological conditions.
Absolutely. You have to consider vasculitis, especially in someone with neurological symptoms and a history of infections.
It's a reminder to think outside the box.
What else did our attending have to say?
Well, they even brought up the possibility of a brain biopsy.
A biopsy?
Wow. If the other tests didn't give a clear answer?
That's a big step.
It's obviously a last resort.
Yeah.
But sometimes it's the only way to get a definite diagnosis.
So now we have a solid plan for the workup.
We do. Let's see what those tests reveal.
I'm on the edge of my seat already.
Yeah.
All right, so what did those tests show?
Well, the MRI showed multiple hyperintense lesions.
Where were they?
Some in the cerebellum and some in the white matter.
Oh, okay.
And here's where it gets interesting. 3 of those lesions enhanced after they gave her contrast. And there was some gyral enhancement, too.
Gyral enhancement. So that's inflammation in the cortex.
Right, which could be a big clue. What about the CSF analysis?
Yeah, what did that show?
It showed a slightly elevated white cell count.
What kind of cells?
Mostly lymphocytes. But here's a curveball.
Okay, I like curveballs.
They found severe hypothyroidism.
Hypothyroidism. Wow, that's unexpected. It just goes to show you can't get too attached to your initial thoughts.
It's so true. You have to keep an open mind and think about everything.
Absolutely.
It really shows how important a complete workup is. So
they started treating the hypothyroidism.
They did. They put her on a higher dose of thyroxine.
Okay.
And her family noticed she was thinking a little better.
Good.
And her mood improved a bit, too.
That's encouraging.
But her apraxia kept getting worse.
Apraxia. So the difficulty with movements.
Yeah, that's the one. It was like taking 1 step forward and 2 steps back.
I know. And what about her other neurological symptoms?
Unfortunately, those didn't really get any better.
Oh, no.
In fact, she even started having anxiety and some unusual thoughts.
Like what?
Almost like she was being persecuted.
Yeah.
And her short-term memory got worse, too.
But her long-term memory was okay?
It seems like they're trying to solve a puzzle with missing pieces.
It is a real challenge. And remember, she's still on immunosuppressants because of the transplant.
Right. That adds another layer of complexity.
It's a tough balance trying to manage her immune system while also dealing with these neurological issues.
So what was the next step in trying to figure out what was going on?
Well, 7 months after her first symptoms,
Wow.
she was referred to a specialist.
With a suspected diagnosis of
multiple sclerosis, MS.
MS. That makes sense with her symptoms.
It does. But our senior resident had some doubts.
What made them question the MS diagnosis?
Well, they pointed out that MS isn't as common in this age group.
Okay.
And it's pretty rare after an organ transplant.
Interesting.
Plus, those enhancing lesions on the MRI weren't typical for MS.
I see. So what did they think it could be instead?
They started to think it might be CNS vasculitis.
Vasculitis, inflammation of the blood vessels in the brain and spinal cord.
Exactly. Which can be really tough to diagnose.
I bet.
But the enhancing lesions and the CSF findings definitely fit with vasculitis.
It's like trying to put together a puzzle.
That's a great analogy. You have all these pieces,
and you're trying to make them fit.
Sometimes you have to rearrange them a few times before you see the whole picture.
So they suspected vasculitis. What did they do to confirm that?
They did an MRCT angiography.
To get a better look at the blood vessels.
Yeah, to see if there were any abnormalities or blockages.
Makes sense.
The repeat MRI showed something interesting.
What was that?
Some of the lesions were starting to resolve.
Oh, wow.
And others were getting smaller.
That's a good sign.
It could be. But there was one lesion in the right parietal region.
Okay.
That involved both gray and white matter.
So it was affecting different parts of the brain.
Exactly. And they got some new lab results back, too.
Okay, what did those show?
Well, her inflammatory markers, ESR and CRP, were elevated.
Showing inflammation.
And she had a positive rheumatoid factor.
Okay.
And a polyclonal increase in IgG.
So definitely signs of inflammation.
Right. And she also tested positive for ANA.
Anti-nuclear antibodies.
Anti-Ro antibodies.
So inflammation antibodies. This is all pointing to an autoimmune disease, right?
You got it. The senior resident was thinking the same thing.
And what was their new top diagnosis?
CNS vasculitis secondary to Sjogren's syndrome.
Sjogren's syndrome. But isn't that the one that causes dry eyes and dry mouth?
It is. It's most commonly known for that.
I didn't realize it could affect the brain.
It can. In some cases, it can lead to neurological problems, including CNS vasculitis.
Wow. So they thought her Sjogren's might be causing the inflammation in her brain.
Oh, they were thinking.
It's amazing how one condition can show up in so many different ways.
It really is. It shows how interconnected everything is. Our expert agreed with this line of thinking.
Did they have any other suggestions?
They emphasized the need to formally diagnose CNS Sjogren's.
Okay.
And they recommended a catheter angiogram.
To get a really clear picture of the blood vessels in her brain.
Exactly. And they were also considering other possibilities like neurosarcoidosis.
Another inflammatory condition.
Right, and Klippers.
Klippers, chronic lymphocytic inflammation with pontine perovascular enhancement responsive to steroids.
That's a mouthful.
It is essentially another type of brain inflammation.
That can look like Sjogren's.
So they were keeping their options open.
Always a good idea. What did they recommend for treatment?
They decided to start her on high-dose corticosteroids.
To reduce the inflammation.
Exactly.
And if that worked,
they would switch her to a steroid-sparing agent.
to avoid the long-term side effects of steroids.
Makes sense. Steroids can be helpful, but they come with risks.
Especially for someone who's already immunosuppressed. So what happened when they started the steroids?
Well, here's another unexpected turn.
Yeah.
Despite the angiogram showing signs of vasculitis,
Her condition actually got worse after starting the steroids.
she got worse. That doesn't sound good. What happened?
Within days of starting the steroids, she developed incontinence problems with her balance. Her walking became unsteady and her confusion and lethargy worsened.
Wow, that's a major red flag.
Yeah.
It suggested something else might be going on.
Something that doesn't respond to steroids the way vasculitis usually does.
So if it's not vasculitis, what could it be?
They were really stumped at this point. And to make things even more complicated,
What now?
a new MRI showed evolving infarcts in her right frontal lobe.
Infarcts, meaning areas of brain damage from lack of blood flow.
You got it.
So now there's active cerebral ischemia on top of everything else. This case is getting more and more complicated.
It really is. Because of the sudden decline, they added cyclophosphamide to her treatment.
Cyclophosphamide, that's a powerful immunosuppressant.
It is. They were getting desperate. The senior resident was still pretty sure it was some kind of CNS vasculitis.
Okay.
And they wanted to be aggressive. They even recommended a leptomeningeal biopsy.
A biopsy of the membranes surrounding the brain and spinal cord.
Exactly.
That's a pretty invasive procedure. Why did they think that was necessary?
They needed a definite answer. They had an immunocompromised patient with a complex history, and nothing was adding up.
So they went for the biopsy? What did it show?
This is where things get really interesting.
I can't wait.
The biopsy showed ischemia, which they already knew about.
Okay.
But get this, there was no sign of vasculitis.
No vasculitis.
Yeah.
But all the signs pointed to vasculitis?
I know it's surprising, but it gets even more interesting. The biopsy showed that the blood vessels in her brain were being blocked by large malignant B cells.
Malignant B cells.
Immune cancer?
Exactly.
The final diagnosis was intravascular lymphomatosis, IVL.
IVL, a rare type of lymphoma that affects the blood vessels.
And often mimics other conditions, especially vasculitis.
Wow. So all this time it was cancer pretending to be something else.
It was a real case of mistaken identity.
Incredible. I can't believe they were able to figure it out.
It shows how persistent they were and how dedicated they were to finding answers. So, after all that, it turned out to be IVL. What happened next?
Did they start treatment right away?
They did. They immediately started her on aggressive chemo and radiation.
Right.
Sadly, it was too late.
Oh, no.
Despite their best efforts, she passed away 9 months after her symptoms first appeared.
That's heartbreaking. This case is a real roller coaster. It's amazing how much they learned, but it's so sad that they couldn't save her in the end.
It is a tragic outcome. But, as we've discussed, this case is also a powerful learning experience. It highlights so many important lessons about clinical reasoning, diagnostic challenges, and the complexities of medicine.
It really makes you think. What are some of the key takeaways for you?
Well, first, it reminds us that even the most experienced clinicians can fall prey to anchoring bias.
Right.
They got so focused on vasculitis that they almost missed the real problem.
It's a good reminder to always be questioning your assumptions and considering other diagnoses.
Exactly, even when you think you have it all figured out.
What else did this case teach us?
It also highlighted the importance of timing and technique when it comes to biopsies.
Yeah, a brain biopsy is a serious procedure.
It is. But sometimes it's the only way to get a definitive diagnosis.
Like we saw in this case.
Right. They might have found the IVL sooner if they'd done the biopsy earlier.
That's a tough call, though, isn't it?
It is. You have to weigh the risks and benefits of an invasive procedure like a brain biopsy.
It's a delicate balance. And lastly, I think this case reminds us that even with the best technology, we have its limits.
Absolutely. Imaging and blood tests can only tell us so much.
Sometimes you need to go right to the source.
Like with a biopsy.
To get the whole picture.
I agree. This case really emphasizes how important it is to combine clinical judgment with the right diagnostic tools and to be ready to change your approach as you learn more.
Medicine is as much an art as it is a science.
It really is. I'm curious what you think our listeners will take away from this case, especially those who are residents or fellows.
What do you think are the most important points?
I think this case really pushes the idea of always learning and keeping up to date on rare and challenging conditions.
Right.
Like IVL, it's
Yeah.
not something you see every day, but knowing about it and how it can mimic other conditions can be crucial for early diagnosis and treatment.
Makes sense.
And it also highlights how important communication and collaboration are between doctors.
The senior resident and the attending in this case worked together really well. They were always exchanging ideas and reevaluating their approach.
Which is so important in these complex cases.
It's not just about individual brilliance. It's about teamwork and making decisions together.
Exactly. And I think this case also serves as a powerful reminder of the human side of medicine.
Absolutely.
We're not just dealing with diseases and diagnoses. We're dealing with real people, with families and lives.
It's so important to remember that.
We need to approach each case with empathy, compassion, and a commitment to providing the best possible care, even when things are uncertain and the diagnosis is challenging.
That's a really powerful message. This deep dive has been an incredible journey for us. Going through all the twists and turns of this medical mystery, it really shows the challenges and rewards of clinical practice, the importance of lifelong learning, and the profound impact we have on our patients' lives.
Well said. I hope our listeners found this case as fascinating and thought-provoking as we did. It's a reminder that even in the toughest situations, we can learn, grow, and try to improve the lives of our patients.
This case has definitely given us a lot to think about. It reminds us to never stop learning, never stop questioning, and never forget the human side of medicine.
Until next time, keep those brains engaged and those hearts compassionate.
And always remember that behind every case, there's a person. And it's our privilege and responsibility to advocate for them every step of the way.